Welcome to our sonography lecture on abdominal pathology, part 404, where we'll take a look at the abdominal wall pathology for the sonographer. This lecture will cover topics such as rectus, sheath, hematomas, endometriomas, and hernias. We're going to begin with a rectus sheath hematoma. Rectus sheath hematomas are basically big bruises that happen within the covering of the abdominal muscles called the rectus sheath. Rectus sheath hematomas are not always the first differential that comes to mind when a patient presents with abdominal pain, and so therefore it can actually be a common clinically misdiagnosed cause of that abdominal pain. What typically happens is that some sort of trauma happens to the superior or inferior epigastric arteries, causing them to bleed into the covering. Rectus sheath hematomas are the result of some sort of trauma or injury to the rectus sheath itself or to the inferior or superior epigastric arteries that run in the same area. Anything that causes extreme use of your abdominal muscles, such as childbirth, sneezing, coughing, defecation, can all cause the rectus sheath to tear, therefore resulting in a hematoma. Clinically, patients are going to present with abdominal pain in the area of the tear or the bleed from the epigastric arteries. There might be a palpable mass where that blood collection is. We might see some discoloration like a bruise, and if the bleed is active and large enough, we might actually see a decrease in hematocrit. On ultrasound, then, we are going to see a collection of blood in the superficial layers of the abdominal wall, and its appearance is going to be directly related to the age of the blood. Remember that anechoic blood usually represents fresh blood, where isochoic, or maybe some like little flecks in there, would represent blood that's beginning to clot off. And then as blood sits in the area long enough, it becomes liquefied again as the body reabsorbs the hematoma. And here's an example of a rectus sheath hematoma. We can see that it is above the rectus sheath. In between the covering and the skin line, we have a large fluid collection. Next on our list of abdominal wall pathologies, we're going to talk about endometriosis and the appearance of endometriomas. Now, endometriomas occurs when functional endometrium leaves the uterus and becomes ectopic. Once it leaves the uterus, it can implant anywhere into an ovary, into bowel, or into the abdominal wall. And it turns out that the anterior abdominal wall is the most common location for endometriosis to occur. Now, this is usually because when a patient has a C-section, they cut through the layers of the abdominal wall into the uterus, and some of that functional endometrium cells are kind of displaced into the incision and implant into that C-section scar. Now, because endometriomes respond to hormonal changes in the body, these ectopic areas of endometriosis are also going to respond to the hormonal changes of the body. So when a patient has an endometrioma in the abdominal wall, typically at the C-section scar, they're going to complain of cyclic pain in the area. Some clinical signs and symptoms of endometriomas of the abdominal wall do include a history of endometriosis, a prior C-section, pain that matches up with the patient's menstrual cycle, and possibly a palpable mass in the area. On ultrasound, then, what we are going to see is a hypoechoic, well-defined structure within the superficial layers of the abdomen wall. And so here's an example of a hypoechoic mass. This is representing endometriosis within the abdomen wall. We can see the skin line here and the rectus abdominis muscles. Now, the last topic that we need to discuss are hernias. So hernias are basically when one anatomical structure passes through an opening into an abnormal space that it shouldn't be. So quite often we think of bowel moving into another space. That's probably the most common thought when it comes to hernias. However, there are other types of hernias. You can actually have your stomach move into a different, into the thorax, going through the esophageal hole in the diaphragm. And so there are different types of hernias, but we're going to focus mostly on how bowel can herniate through an abdominal wall defect to become what we know as hernias in the basic sense. So with the abdominal wall hernia, they may be congenital or acquired. So if the person is born with abdominal defects in the abdominal wall, they are going to have that congenital hernia. Or if you think about like when people are like, oh, I lifted this heavy box and I felt this tear, they're acquiring the hernia. They have created a defect within the abdominal wall for bowel to pass through. Again, there are very many variants on the abdominal wall hernia, mostly distinguished by the location of the hernia and what's inside the hernia. The most common type of hernias of the abdominal wall are going to be inguinal, so in the groin area, followed by umbilical hernias, which happen at the belly button. Diagram here shows us multiple areas of the abdominal wall that hernias can occur. Again, inguinal hernias are the most common, followed up by umbilical hernias. Some other types of hernias that we can have then are epigastric hernias that occur in the epigastrium area of the abdomen. Spiglian hernias, which occur along the abdominis muscles. Femoral hernias, where the bowel extends down into the leg. And we can also have incisional hernias, where the incision weakens the abdominal wall and allows bowel to herniate into it. So taking a closer look at inguinal hernias, the inguinal hernia is going to occur when tissue such as the intestines or fat within the area is going to protrude through a weak spot or an opening of the abdominal muscles. Typically when this happens, the bulge can be painful, and it's usually more prominent when you cough, bend, or pick up a heavy object. So we quite often see these on males. They will have an inguinal hernia. The intestines herniate through the abdominal wall covering and into the scrotal sac. So again, inguinal hernias are the most common. In females, it's not uncommon for that intestine to herniate into the labia. If we look at the umbilical hernia, again, we have the rectus sheath covering, the muscle covering. There's a gap in that area which allows fat and bowel to herniate through the hole, which is visible then at the belly button. Now there are some complications that can come along with hernias, and as a sonographer, you want to kind of evaluate where the patient is with any of these complications that can occur. Now one of the big things that we see with hernias is that if you push a little bit on the hernia, you can reduce it, which means it goes back into position. So if you put a little bit of pressure on the hernia and it goes back in, that's a good sign. However, if you put a little pressure on the hernia and it doesn't go back in, there's actually some concern that the hole in which the hernia originally took place through is now starting to constrict on itself. And what most often happens is that edema is going to build up in the area because it doesn't like that this herniation is there. Edema starts to build up in the area, starts to swell, and it causes that hole to become smaller, which means we can't get the intestines back to where they should be. Now, if that happens for long enough or gets tight enough, the next complication that we see is strangulation of the hernia. Strangulation of the hernia is going to cause blood flow to stop flowing to the bowel and fat that is within the hernia. So once this happens, we consider it an incarcerated hernia, and that has to be surgically repaired. If that bowel sits long enough without blood flow to it, it is going to die. And if it dies, it becomes necrotic. And what's going to end up happening is they're going to have to remove that whole section of bowel and sew different pieces together to reconnect the bowel and make it healthy again. So on ultrasound, we have a few things that we need to prove when we see a hernia. The first thing that we want to really take a look for is, can we see the abdominal wall defect? You're going to watch through the muscles and you're going to look for an area that has a gap, that is not a full continuation of the actual muscle. Next, you're also going to look for presence of bowel loops in areas that you wouldn't expect them. So you might see some bowel down where you expect it, and it's going to swoop up more anteriorly as it herniates through the wall defect. If you can see some peristalsis in that area, that confirms that bowel has indeed herniated through the abdominal wall defect. Sometimes it might just be very echogenic material in there, which typically represents mesenteric fat within the hernia. Another thing that you're going to want to do is exaggerate the hernia to prove that it is indeed a hernia. The way that we exaggerate the hernia is to have the patient strain. And there are two ways that we can do that. The most common way that we should always do with all of our hernia checks is to have the patient perform a Valsalva maneuver. Now, there are a couple ways to explain a Valsalva maneuver to your patient. You will find the best way that works for you. But essentially what it is that pressure that you create in your body to have a bowel movement is the Valsalva maneuver. And so you need to express to your patient how to create that pressure within their body. Sometimes it's a matter of saying, take a deep breath in and kind of flex your abdomen muscles. That usually helps. Sometimes people get a little aggressive with that and like do a full-on sit-up, which then ends up knocking you off where you're looking and is not very good for imaging. So sometimes you need to explain it to them in a different way. One of my favorite ways to get people to do a Valsalva maneuver if they're struggling following those directions is to either describe it as, it's the way you poop, or what I have them do is take their thumb, put it to their lip, and pretend they're blowing up a balloon. That pressure within their thoracic cavity and in their abdominal cavity, as if they were blowing up a balloon, their thumb balloon, actually provides a very nice Valsalva maneuver. The other thing that you may need to do to exaggerate the lesion is to have the patient stand. This is most likely going to be done with more inguinal hernias. And so you have the patient stand up. That causes the bowel to become dependent, falls towards the pelvic floor, which then also causes it to herniate a little bit more obviously through the inguinal opening. The next thing you want to check then is, can you reduce the hernia with a little bit of pressure? Can you get it back into the area that it belongs, or is it impossible to push it back? If we cannot reduce it with a little bit of pressure, that patient is going to need surgery sooner than later. So here's an example of an inguinal hernia. The calipers on here are showing the defect in the wall, the neck of the hernia. So this is all bowel that is coming through and bulging into what looks like the top of the scrotal sac. If this was a live picture, we would see peristalsis through here. We would see the bowel matter moving through and kind of looping around. We want to put color on this, make sure that this area is still getting blood flow. So determine if it's incarcerated or not. Can we get it to go back to where it belongs? The next thing that we'll want to do is make sure that we have the patient Valsalva. Usually what happens then is this whole structure, all of this bowel, will start to slide further into the scrotum. It becomes very exaggerated. And so we'll want to take a cine clip of that occurring. Here's an example of a ventral hernia. So we can see a muscle wall here, and then we see a little bit of a gap there, and then we see a continuation of the sheath and the muscle continuing on. So through this very small gap here is the abdominal wall defect, and then we have this bowel that has herniated outside of the area that we expect it to be. So this is the long view of it, and this is the transverse view. Again, we can see that gap. This would be a continuation of the abdominal contents moving up and out of that muscle wall. Here's another example of an umbilical hernia. Again, we can see the rectus sheath covering here. We can see the muscles beyond it. We see a gap then, and then we see the continuation of the sheath. And so here we can see mesenteric fat has protruded into the umbilicus. If we put color on here, we'd probably see a little bit of color flow in there. We'd want to evaluate, is there any bowel within that as well? Again, we're going to have them Valsalva. This area will get larger, typically with that Valsalva. So I have a video here that we'll take a look at. So here we can see the bowel loops. This is all bowel here. We can see it peristalsing. So we want to make sure that we're seeing peristalsis to prove bowel loops. We want to use color, make sure this area is all getting color flow. Typically, you're going to use linear transducers to evaluate for hernias. We want really detailed information so we can identify where the gap is. There you can see a little bit of that peristalsing. And you can see just with the patient breathing, you can kind of see the hernia itself kind of moving in and out of the area. Let's take a look at another video here. We've got a video of a ventral hernia. So again, we're going to use a high frequency transducer. We're using a body marker on the side here to show the radiologist where we are placing our probe. And we're going to use that high frequency transducer to evaluate the rectus sheath. We're going to look at the abdominal muscles, and we're going to look for a gap in which bowel is moving. So you can see this person is breathing or possibly valsalving. You can see how that bowel was moving in and out of the defect. So we have gut loops that are coming in and out, or bowel loops. And then here, these arrows are pointing out the gap. So we want to measure this area. It helps the surgeon to know how large of an area they are working with. And that brings us to the end of our abdominal wall pathology. Thank you so much for watching. If you haven't already, check out the other videos in this series. Part 1, abdominal lymph nodes for the sonographer. Part 2, GI tract pathology for the sonographer. And Part 3, peritoneum pathology for the sonographer.